Public dialogue and civic engagement are important. They play a role in improving the health and well-being of Texans across our great state. That's why Blue Cross and Blue Shield of Texas is proud to support Texas Tribune events like the conversation you're about to see.
Please welcome, especially these two representatives. So today, unlike some events we put on, we only have one topic and we only have two of you. So we get to stretch our legs and talk expansively in long form about this subject of healthcare. And I want to begin not so much looking ahead to the session, although that's where we're going to spend most of our time, but I want to look back. As we sit here today in the current biennium, if you look at the all funds budget of the state of Texas, healthcare is about 37%. It is, for the first time in the history of Texas, equivalent in the percentage of the all funds budget we're spending to education, roughly. It was not the case. Education used to be number one, far and away, no close second. So healthcare costs have been hockey sticking in the state of Texas. I wonder how we got here, Representative Zerwas, Chairman Zerwas, Dr. Zerwas. How did we get to a point where we're spending so much on healthcare and where it is threatening to be budgetarily the beast that ate Cleveland? It's just crowding every other priority out of the budget. How is it that we got to this point?
The way you described it is great. I know I'm echoing a little bit, but I assume the sound guy will take care of this.
Yeah.
But I describe it as the cash-hungry beast, and I borrow that from Charles Krauthammer, who was looking at this at a similar, sort of from a similar perspective and stuff. Ultimately, it's the Medicaid program. That's what Article 2 really is all about, although there are some other things in there, as we know. But right. Medicaid plus is the state federal program, joint program, federal matching funds come to it. But the bottom line is, Evan, it's an entitlement program.
Right.
So what it says is, if somebody qualifies, and I'm not saying this is good or bad, but if somebody qualifies based on the parameters that are set by the federal government and by the state, they have to be allowed into the program.
Yep.
And we have to match the money, and that match is a variable depending on what our per capita income is and so forth. It's a complicated formula not to bore anybody with, but when we're doing well, we get less money from the federal government.
Right.
When we're doing less well, which happens to be where we are now, we can expect a little more money from the federal government.
Right.
And so, a big part of the all funds budget, of course, is the federal component of that.
Right.
And the biggest chunk of that does come through the Medicaid program. So
right.
with people coming to live in Texas, not all of them are Evan Smith and live the elite lifestyle,
Oh,
but
yeah. Look at this right here.
A good number
Yeah.
do come, and they need the help of the Medicaid program.
Yeah.
And so a large part of it is simply enrollment driven, and then the cost that is associated with those that actually tap into
and enrollment driven, Chairman, is also population driven in the sense that we live in a fast growing, maybe the fastest growing state, right?
Exactly. The numbers that on a per day number of people, Donna, you remember hearing them, 1,000 plus people a day coming
right.
to the state of Texas. And again, some of them are going to qualify and be entitled, thus it's an entitlement to
right.
this health care program. Now, the costs have continued to go up, just like they have in health care in general. We can't talk about Medicaid separately from the overall cost of health care in general. And so we've seen the costs go up in addition to the enrollment. And the two things together ultimately have led to where we are, and I've been acutely aware of it like you,
yeah.
that we are now approaching the funds, the budget that could very well surpass education this year.
In this next biennium.
I thought it would have happened last time. I think there were some sort of last minute things, and it came in a little bit under. After
right.
we provide the supplement and stuff, it may end up actually being on top of education in terms of its overall costs. But it is a program that is going to continue to challenge us, and it will continue to compromise our ability to deliver on education, public safety,
right.
and infrastructure, which I think are the real big things that state government
Representative, that really is a major part of this conversation. Healthcare costs cost us in two ways. We spend the money, but then we don't spend the money on other things because these are not referendum dollars, healthcare versus not healthcare. They're choice dollars, healthcare versus any number of other things we could be spending that money on. And there are other priorities that are not getting as much because healthcare is getting more, right?
That's one way to look at it.
Yeah.
Am I on?
I wonder if any of us is on. Can you hear us okay? All right, good. It's like an oil painting out there for a little while, so, go ahead, yeah.
There are other ways, I think, to look at this, or at least other factors to consider if you're going to look at the whole picture here, I think. You're talking about all funds. So you're talking about federal and state dollars together when you're making the original statement that you made about how healthcare costs are approaching, or maybe even surpassing education costs. And when we're talking education, we're combining public and higher education.
Right.
If you look at the state dollars, the general revenue dollars, it's a little different picture. You're not close like that. I don't remember the exact numbers, John, you might, but it's for healthcare it's 30-something, and for education it's 50-something.
Right.
So we don't see that same kind of issue when we're talking about the actual dollars that we're appropriating.
Right.
So that's a little bit of a different thing. The other thing I think we need to think about when we're analyzing this is how the state has continued to, the state's share of public education has eroded in recent years as property values have gone up. And so you see a decline in adjusted dollars, and even some in raw dollars when you're looking at certain years in public education spending. So healthcare costs can be going up while public education costs are going down simply by virtue of how we're appropriating them.
So you think this is a decision that the state has made?
I'm saying that there are other factors. And yes, everything is a decision that we make. We decide how this is done. We have certain parameters, but let me just say one other thing about it, and that is the size of the pie. Because if you keep the same size of the pie and healthcare costs go up, and the state's spending less on public education, then yes, you're talking about some cost shifts there. Whether or not healthcare is really pushing out other things, I think is all in how you're looking at the pie.
If the pie were bigger, it would not be pushing out other things.
Correct.
Right. You know, the federal piece of this, I mean, I appreciate your clarity on the difference between the state and the federal piece of this, but of course, for the last 6 years, we've been thinking about healthcare in a federal sense because of the Affordable Care Act. The history of this is known to everybody in this room. Affordable Care Act was signed into law in March 6+ years ago. Texas was one of the states that resisted embracing the Affordable Care Act. We didn't expand Medicaid. We did not create an exchange. The uninsured population of the state, which was the worst in the nation or the top in the nation, depending upon how you look at it, continues to be, but it has declined from 25% to 17.1%. We're now entering a period of time, we'll talk about what happens next when we'll see a big change at the federal level, but I wonder if you would each, Representative Howard, you first, was the Affordable Care Act a good thing or a bad thing over these 6 years? Just this morning, Paul Ryan, the Republican Speaker of the House, tweeted something to the effect that after 6 years, one thing is clear, the Affordable Care Act failed the people of this country. He is, that's not a new statement for him, but his position is that. You agree with that it failed us?
No, I do not.
Yep.
I agree that there are some issues that could and should be addressed, but when you have 1 million more people receiving insurance, like we have here in Texas, when you have people able to get coverage up to the age of 26 on their parents' plans, when you don't have pre-existing conditions as part of the obstacle to getting coverage, when being a woman is not a pre-existing condition, those kinds of things, I think that's a positive thing. We've got more people covered, and that provides more access to care. The fact that we did not expand Medicaid has been a complicated factor, of course, for what we do here in Texas. But in terms of having greater coverage, in terms of more people having access to care, I don't see how that could be called a failure. Realizing that there are things that we could adjust here, that there are some blips here. I think the way I kind of look at it is you're trying to put a square peg in a round hole. We tried to come up with not we at the state level, but
the royal we.
Yeah, the royal we. It came up with a plan that was a kind of a hybrid. Instead of universal health care coverage, it was to try to use the private market and public together. And that's a very difficult thing, I think, to make work out. And then with all the partisan politics that kept us from really addressing tweaks along the way, we have something that's unwieldy right now, but should it be done away with? I do not think so.
Chairman, the fact is every big law and small law, but particularly every big law that's ever been put into effect in this country or in this state is tweaked. It's never perfect on day one. Why not tweak it? If there are things wrong with it, why not tweak it? Or do you think that over the last 6 years, the Affordable Care Act has been net not a good thing for us?
Well, when you speak of tweaking it, it's the magnitude of the tweak, I would tell you. And I'm not quite the same place where my vice chair is on this in terms of has the Affordable Care Act been a success? I think if we just look at it from a financial point of view, it has not delivered. Okay, we have seen the cost of health insurance continue to go up significantly,
Yep.
and I think that that's not an unexpected thing when you look at what the incentives or the disincentives were that were put in place. I mean, the bottom line was, excluding the expanded Medicaid group, which I agree with Donna is an important thing for us to think about here. But we didn't get all the young, healthy people piled into the plans to take care of the old people like me, who have medical conditions that need to be handled and stuff. And I mean, that's a very simple thing. And a big part of that assumption was that everybody would have to expand the Medicaid program. And that didn't happen. So I think that's where part of the rug got pulled out from individuals that are from the people that were sort of putting this thing together. And so, I would say though, eliminating pre-existing conditions as a cause for not getting insurance, I think that all of us would agree that goes away. And all of us would say it's not inappropriate to pay a little more money in our premiums in order to make that happen. Kids on till 26, fine, I missed that boat, but that seems to be something that, a lot of people who are there say that's a good thing. And I think even the president-elect has said these things, that those are things that probably are worth keeping,
Well,
but
the president-elect has said a lot of things. I could just end the event right there. He talked about repeal and replace all through the campaign, and now that he's gotten in as the president-elect, he, as you suggest, has started to say, well, but the pre-existing conditions thing, people like that, or the 26-year-olds on their parents' insurance, like that. The plan still seems to be to pull back on this. There's a sequencing issue that is not yet resolved. Are we going to repeal and then wait until we have a replacement to actually repeal? In other words, will we repeal and then say, but we're going to defer the repeal until we have a plan? Or are we going to repeal and basically pull the rug, as some would say, out from under those who received insurance in the last 6 years and then eventually come up with a new plan? What's your belief in how this should be done? If you could wave the Zerwas wand over this, what would we do? Because it's going to have an impact on your conversations in this next session.
Oh, absolutely, I think. I think, one, I do think that they will move forward with some type of a repeal effort. You can't deny that that's something that has happened out there, that people campaigned on, and let's face it, the House of Representatives up there have passed a law several times, to say we want this thing repealed.
Right.
So I think that's going to happen. The sequencing, I think, is probably the nuance here and stuff. And so I think how you ultimately repeal and then integrate a replacement strategy is yet to be determined. I know that there's obviously a lot of conversation up there. This is basically the old the dog caught the car finally. So okay, we caught it. What do we do now? We can repeal it. We've got the votes to repeal it.
Right.
But do we have a good, strong, sound strategy in order to make sure that people can access affordable
So
health
all those
insurance?
times they voted to repeal, they didn't actually have a plan over here waiting for them in a drawer?
Well, I think I think the new HHS secretary, or to be named, Dr. Price, has a lot of ideas, and I think that's what a lot of this is. It's ideas that would take advantage of the marketplace to try to drive affordable health insurance products. They've yet to be determined if they'll work, but on paper they look pretty good. So, but I think that what they're going to be faced with, this one didn't work, in my mind. That's why we're looking at repealing it. What are we going to do to provide what's missing here, which is the affordable part of it, that's going to continue to allow us to stay, or perhaps even get better than that 17%.
And you hold open the possibility, Chairman Zerwas, that there will be a top-down plan, some other government plan or federal plan, or is it simply going to be what has been discussed in Texas forever, which is that a stork flies over all 50 capitals and drops a big cartoon bag of money, right? That every state receives back in the form of a block grant all that money that they've been asking for the last 6 years, and the federal government's attitude is basically, you guys go figure it out one at a time.
Well, I don't think that'll happen, but that's probably something that a lot of people dream of, you know. It's not going to happen that way. I think I do think that there will be an effort to move towards a block-style funding for Medicaid programs.
Right.
And I think that there will be given perhaps a lot of flexibility to the states to come up with the appropriate program that fits the needs of their particular state. So
Right.
I think that will happen. Whether that happens in this biennium or not, I think is questionable, frankly. But I do think that there is the sentiment. I think they'll accept that they have a spending problem at the federal government level. This is a way to wash their hands of it, send it down there. You guys take care of it. These are the things that we expect, you know,
Right.
access, quality, the typical things that you would talk about, and prove your performance on that. And so, you know, there's a lot of detail that comes in. How do you calculate that amount of money? You know, how do you figure out what the benefits program should be, since you now have your arms around it?
Right. Representative Howard, we in Texas like to determine our own present and our own future. That's a standard when you arrive at the state lines. That's one of the things they say to you about Texas, is that we're going to determine how we do things. We're going to do things our way. And how we do them may not be the way other states do them, but we're Texas, we know better, we understand what works for us. Why wouldn't we want to have the opportunity to craft our own solution, disengaged from the federal government?
Well, quite frankly, the Zerwas magic wand was going to do that at one point. Several sessions ago, we did have a bipartisan plan to do that.
And then the leash was yanked,
Texas
if I
model.
remember, right?
Well,
It was yanked hard.
Was yanked hard,
I
right.
still got scars up here. So.
Right, yeah.
so I think there was an effort in the legislature to do something in a bipartisan way, and it was possible. We really had a good, strong majority in the House anyway, and it didn't end up happening. We didn't even
Right.
get to take that vote. And then there really hasn't been an opportunity since then for it to come back up. You know, I'm not sure, obviously none of us knows right now how this would happen. The talk is of the budget reconciliation and looking at historically what was done before that the president vetoed. And if you look at that, then, you know, you kind of have to wonder how this is really going to come about if they're going to be cutting those federal funds or repealing that, the federal funds. It's going to create a huge disruption in the system.
Well, and in the lives of individuals who have lived under this
yes.
system for the 6 years, right?
Yes. If you have this million some odd people
Right.
losing their insurance coverage, and I think it's something like 84% of those that are getting on the individual market are getting subsidies
Yep.
from the federal government. If that money goes away, where are they going to get? How are they going to be able to afford
Right.
on the private market what they're having a hard time affording right now, with the subsidy?
And that gets to the sequencing question. So I asked this question of Donna Campbell, state senator who represents San Antonio, and Dawn Buckingham, who was an incoming state senator who represents Travis County and parts north, each in the last week. And I said, what happens if they repeal? Would you wait for the repeal to take effect until they replace? And both Senator Campbell and Senator Buckingham said, nope, remove people from insurance immediately. Even if there's no replacement, let the private market take care of it. Is that your view?
No, that's what I'm talking about, being disruptive. No, those are both positions, right?
And those are both physicians.
Right.
Right.
I don't understand how that could work at all when you have the rug pulled out from under these folks. The rates have been set for this next year. If the money stops coming in, the
Right.
premiums stop being paid midstream, what's
What
that going to
happens?
do to the insurance market? What's going to happen? It's going to fall back on the providers. What's going to happen to those that had coverage that aren't going to have it?
Chaos.
And it is chaos,
Chaos.
absolutely.
So tell me then, materially, can there be an impact on the state budget in the next session based on what the administration is? I mean, I'm trying to think about this. You know, border security is another, we're not going to talk about border security today, but another conversation where people say, well, with the Trump administration instead of the Clinton administration, we may be able to reduce our spend on border security because now you have an administration that says they're going to take care of it. That was our complaint before. On health care, with the Trump administration in, potentially there's a way for us to rejigger our spend on health care, but we don't, it's going to be too soon, Dr. Zerwas.
I agree. We, as you mentioned, on the Legislative Budget Board, we've just finished our what we call boards of review, where all the agencies bring their budgets and we look at them and say, okay, what's happening? Really none of any, just sort of thinking about what would happen in the incoming administration is even in the equation right now.
Right.
We're looking at, a circumstance. The border thing could be, but we're not saying, okay, we got $800 million more dollars.
Right, but healthcare, there's not really going to be a material difference.
Well, no, I don't think so. If we look at where we are, we've got significant less revenue coming in. We anticipate the VRE on January 9th is going to be significantly below where we are. We set the spending cap at a pretty low level, although we don't anticipate ever hitting the spending cap to begin with.
Right, this is Texas. We never spend all the money we have
available. We never spend it, but this time we won't even come close to that. I'm certain.
We won't come close because the pay-as-you-go limit is going to kick in before we even get to
exactly,
the limit.
Exactly.
And that actually gets to a significant big-picture question that relates to this. We're going to have less money to spend in the next session. Nobody seems to dispute that. The controller says it. Members of the legislature who know how the budget works say it. Could we conceivably see cuts in the area of health care as a result of our need to reduce spending overall? There are only a certain number of places you can go to make cuts in this budget. A lot of the money is spoken for when you walk into a session. So do you think we could actually cut back on healthcare spending to the degree that it would affect people who are expecting that we're going to do things that we're now not going to be able to do?
I would remind you, in 2011, we did that.
Right. I remember quite well.
And it was a pretty significant blow. Yeah. I don't think that this is anything like 2011, frankly.
Right.
We will be lean. We'll have less money. You can't balance your budget when you're looking at reining costs in without addressing the two big behemoth articles, Article 3 and Article 2.
Healthcare.
So, healthcare being Article 2.
Yeah.
And so, yes, you have to give it a good, strong, hard look to say, are there places that we can actually pull back, and actually help us try to bring this budget in. And the same scrutiny will occur across the entire budget, of course.
But the majority of the discretionary portion of the budget is healthcare and education, and it's the old Willie Sutton argument. You go where the money is, right? If you have to cut this budget, then you cut the parts of the budget that can be cut.
Right, and then you have to think about, are you cutting parts of the budget that come with a federal match?
Right.
And so that kind of hurts you twice when you do that.
Yeah, Representative Howard, one thing I remember from the last session was a discussion of the reimbursement rates and how Texas was, I think the House asked for 100% and the Senate wanted 64%. I'm seeming to remember these numbers, and the Senate version of the reimbursement rates prevailed, right?
Yes, we put in, I think it was another $500 million to keep the reimbursement rates up to what was required in the Affordable Care Act initially. And, obviously reimbursement rates are a huge factor in access to care.
Right.
And
and the number that ultimately prevailed in the budget was a not terribly generous reimbursement rate relative to what some had wanted to do.
The Senate's version, which is what was in the final budget, did not include that $500 million.
Right, and I think right now the number of doctors who take new Medicaid patients in Texas is down in the 30% range, is that right?
Low 30s.
It's at a quite low number. And if the Medicaid reimbursement rates are not increased in a tight budget, may even have to not stay where they are, I mean, that's going in the other direction in terms of giving people access to docs and to care, right? Today is the 15th of December, is it not? Today is the day that the cuts to the therapy rates got cut, right? This is a very controversial aspect of the conversation we're having. How are we feeling about that, Dr. Zerwas?
Well, I'll echo what Speaker Strauss said. I'm on paper and very clear that I've never supported the rate reduction.
Yeah.
That this is something.
Explain for the benefit of our audience what
we're
talking about.
So we're home therapy rates and things of that nature, and things that take care of sort of fragile children that have some needs that keep them out of the hospitals ultimately, and so there are a variety of whole different therapies are just lumped together as one, and they were identified in the budget as a place that we could really draw in some savings, and what that means is we're going to pay you less money. And so what we found, though, is that, and again, I was not directly involved in the budget decision making at this time around, but what we found is that was going to compromise the ability for some of these kids to access services and stuff.
Right.
And I think it's a very real thing. And so the Speaker has spoken out on it. We understand that that's something that really needs to be looked at, in a different way.
Well, the Speaker has said he wants to come back in and in the supplemental budget, basically go back and make those
Right, make 'em
reimbursement
whole.
rates
Make 'em
whole.
whole.
But the problem is that today is the 15th. Today is the day that they go into effect. And at least for a period of time, those cuts are going to be the law
Correct.
of the state. Can the House just summarily come back in and say, we're going to reverse this without the Senate's assent?
Yes, we can, despite what the Senate thinks.
How? Oh, we can say it.
Look right into camera. Speak to the lieutenant governor directly. So I mean, I want, when the speaker said this to me 2 weeks ago, I want us to go back and undo this thing that we did that we shouldn't have done. But of course, my thought at the time was, I didn't know that we only had one branch of government.
Right. Obviously, I'm being facetious in that, but although the Senate sometimes has that same perspective. So, but
what's good for the goose.
Yeah,
right?
exactly.
Yeah.
So, no, I think we're going to have to take a critical look at it. And truly, if it's what we anticipate it to be, we're going to be a month down the road when we go into session. There's going to be, what I call those poster children of things that have happened as a consequence of access of care being compromised.
And parents with pitchforks and torches storming the walls of the Capitol, right?
Well, sometimes it feels that way, but no, it's truly something that where, there's nothing more important to you than your children. Right. And if they are being compromised in their access to some of these services, which are very important, and they are things that keep these kids out of hospitals, which is, we all know, are very high-cost areas of healthcare. And so when you look at the bang for the buck in terms of the things that are being done, this is something that if we can avoid a hospital,ization, an emergency room visit, a surgical procedure, whatever.
Of course you would do
an
it.
intensive care, situation.
Right.
The money becomes insignificant.
Representative Howard, it's interesting, since these cuts were passed into law, and then people became aware of them, people said, well, whose idea was this to begin with? And everybody did this. Nobody wants to take responsibility for having done this.
Well, we have our version on the House side anyway, that we never got a chance to debate this, that this was added to the budget in the conference committee, which is a behind closed doors kind of thing. You've been a part of that.
I've been part of that, yes.
That it came back to us, and when we have the final budget, it's an up or down vote. We don't get to go back in and make adjustments to that budget. And so a lot of us kind of got caught off guard, if you will, by this even being in the budget. And I know Dr. Zerwas wrote a letter, as did many of our Republican colleagues. A bunch of Democrats got together and wrote letters about it, trying to get some action taken earlier in this process, earlier in the interim. This was actually started last summer. And one of the things we had suggested is that the leadership call together the Legislative Budget Board, and they could have actually taken some action at that level. That never happened. And even though today's the day it goes into effect, some of the providers have already shut down their practices, especially in, I think it was East Texas, 300 kids have now had lack of access to care, and that's only going to increase now, even if we are able to win over to getting it in the supplemental. And just by experience of what happened with women's health care in the 2011 budget cuts when all those family planning clinics were shut down, we are still, at this point in time, even though we've put money back in.
You're digging out.
We're digging out. We're not seeing the same number of clients that we were prior to those cuts. Even though we've put the money back in, you do not just put Humpty Dumpty back together again.
Put more money in it, in fact.
That's correct. We are. But we're still not seeing.
You don't rebuild it overnight.
So that's the part of the problem here is they're also going to decimate something that currently exists, and we can't just rebuild it immediately.
So this is my question, and I'm asking this not in any snarky way. I'm not asking this pejoratively toward the two of you, but what have we been talking about lately? We're talking about cuts to Medicaid reimbursement rates for the most vulnerable kids, therapy for the most vulnerable kids, vast underfunding of child protective services, apparently to the point that it is the rare bipartisan issue in this legislature and is going to come back as an emergency on everybody's radar screen. And there's been remarkable reporting in the Houston Chronicle over the cutbacks on special education. What is it that the legislature has against vulnerable kids?
Really?
I think it's an unfortunate confluence of issues that are unrelated, but when you look at them together, Dr. Zerwas, would a resident of the state of Texas be forgiven? Shouldn't one be forgiven for looking at the legislature and going, what the hell are you guys doing?
Right. Yeah, no, I mean, believe me, we get that a lot on any number of issues out there and stuff. And, I would just say this, is that, again, going back to where can you save the money, and I think the special ed is kind of a different situation here. But, where can you find, substantial chunks of change in order to rein in spending, And even though we didn't have, a lot of, shackles on us this last time, we had significant amount of money available to us to do things. The pace of growth of the Medicaid program that we've already talked about and the people that need those services is significantly outpacing income, even in the times when the price of oil is doing extraordinarily well.
Yep.
And so we're gonna continue to see that, despite the fact that we've got less revenue coming in, and we're going to have to take some serious looks at it. I don't think any of us.
They're only hard choices, right?
They're all hard choices.
Yep.
I mean, do you start looking at? Let's face it, one of the bigger issues in the Medicaid program, which is elderly care.
Yeah.
I mean, that's where a huge chunk of change
And
goes.
people don't talk about, we hear a lot about demographic change and what the demographers are predicting by 2040, the state will be 55% Hispanic, 32% Anglo. You hear a lot about that. But in that same time frame, the population of 65 and older in the state of Texas is going to double. That's another ticking time bomb from a budget standpoint, is it not?
Oh, absolutely. I mean, if you look at, the relative numbers, there's a large number of women and children in the Medicaid program. But if you look at the dollars that flow out, it goes towards elder care.
Older people,
and,
right.
Absolutely.
Right.
So the things that we can do to try to reinvent, and we've done some of this with some waivers and things that we have.
Yeah.
And in fact, Texas has actually been something of a leader in looking at ways that we can, keep people at home, so that they can age in place and do the things that typically you would want to do. So we've been really, I think, pretty progressive in some of those areas.
Let me ask you about another aspect of this. I always think about the problem that we have in this state with access to coverage. That gets to the uninsured population, but we have an access to care problem as well. It's often said that if we had at any point in the 6 years expanded Medicaid, and all of a sudden everybody who didn't have health insurance in the state of Texas now had health insurance, there wouldn't be enough doctors. There wouldn't be enough venues to treat them. And I know that tort reform was supposed to do some of this. Floodgates were going to open. But the reality is that of the 254 counties in Texas right now, more than half are health professional shortage areas designated by the federal government. More than half of the counties in Texas. 35 counties have no doctors at all. 80 counties have no surgeon. 80 counties have no gynecologist. 80 counties have no psychiatrist. So I wonder, Dr. Zerwas, what can we do to solve that piece of the puzzle? How do we create more medical professionals to in turn treat all these people coming to the state of Texas?
Great question, and it seems like everybody's opening a medical school these days in an effort to try to address that.
That's a good thing?
Well, it's a good thing if you're going to give them a graduate medical education opportunity in order to get ultimately educated in the state, because otherwise they're going to leave the state and they're going to practice wherever they do their GME. And so that's an ongoing conversation. We need more graduate medical education opportunities. We did a pretty good effort at that this last session, but there are people that want to open either a DO school or else an MD school out there.
You're going to come back and do more on GME stuff and residency slots in this next session?
Well, it's going to be tight to be able to do anything more than that. We found a chunk of change in the old joint underwriters plan that was able to mobilize that and use that to fund these expanded GME spots. But it will be very short order, just with the opening of RGV and Dell Medical School, that you're all of a sudden going to have more physicians. I don't think that's the solution. And Representative Howard and I agree to some extent on this solution, but we do kind of divert at some point. And that is that to take advantage of other people that are not physicians that can help us deliver care out there. And the two things that I think that can really facilitate that, one is the use of people like advanced practice nurses and physician's assistants.
So-called scope of practice stuff.
Yeah, I won't call it that, but I would say that there are people that are better trained than they were 10 years ago, 20 years ago, that can work in a healthcare environment in a team concept, which I highly support, and take advantage of technology. There's going to be a lot of conversation around telemedicine and what constitutes an appropriate patient relationship and so forth. So I don't think that we have nearly tapped into the potential that telemedicine can bring, as well as tapped into the skill sets of advanced practice nurses.
But up to this point, Chairman, and then we'll go to Representative Howard on this, up to this point the legislature has been cool to both of these topics. Has
Well,
it not?
I think I think that ultimately, and this is where Representative Howard and I probably go different ways, and that is, where is the practice of medicine, and how can we best make sure that the practice of medicine continues to deliver, the care that is necessary out there. And I think that it can be delivered effectively, and it's been shown through telemedicine, as well as having, a set of hands and eyes that can actually be on site, see the patient. And that can be, an advanced practice nurse, or that can be a physician's assistant. There's a lot of detail in that, and where we do get derailed is where we say, okay, a person who has not completed a medical curriculum is now starting to wade into the practice of medicine.
Right.
And is that starting to compromise the health care of the individual?
Representative Howard, this is what we might call an any and all strategy, right? Are you willing to consider that we can add these additional opportunities to help some of the rural areas of the state, or some of the areas I've described that are just completely without medical professionals? Are you comfortable with it?
Well, I agree with Dr. Zerwas that you have to look at the practice of medicine and protect that. But what we're talking about here with advanced practice nurses is actually highly trained, qualified people practicing to the full extent of their license and training. There is always going to be some overlap. There's overlap in nursing and medicine, but they are different. However, I don't think anybody's proposing to provide something that's less than. The studies that have been done indicate that advanced practice nurses, when they're providing primary care, the outcomes are as good as, if not better than, that provided by a physician sometimes.
So what's been the obstacle of the legislature to getting this done?
Just what I think Dr. Zerwas said. The obstacle has been that there is a belief among some that this would be lessening the quality of care. Almost half of the states in this country allow advanced practice nurses to practice to the full extent of their license and training. That would go a long way toward helping us with the shortage of providers and access to care. We need more physicians. We need more physicians doing primary care. We also need, there's shortages of certain specialists. There's a lot we need in both professions.
Right.
And the telemedicine as well. I mean, all of these things need to be put to good use to get past some of the political obstacles that have been in place and make sure that Texans have access to care. I just talked with a physician this week who is part of a program that has been getting some funding from the state dealing with strokes, and in rural areas in particular, using telemedicine with a physician in the ER there. So you've got a physician present there, but they're connecting then with the people who have this expertise on diagnosing the stroke. And then they have I think they referred to it as something like nurse car. It's like patterned after NASCAR. It's a team approach to getting in there and doing some interventions immediately, and the outcomes are amazing in terms of what they can do to sustain life here and prevent further injury. There's so much that can be done. There's no reason for us not to embrace this and look at how we can make it work.
You think the legislature, either of you, has a stomach to tackle some of these issues in this next session?
I do.
Oh, absolutely, and I think we will. I mean, if you think about, one of them that has is in the headlines a lot right now is the whole teledoc issue, which is just the idea that, a physician who has a medical history of somebody, their plan offers them the opportunity to call one of these doctors that participate. That doctor can consider what the person is telling them and actually prescribe over the phone without having had a face-to-face contact with that particular patient. We're going to have a conversation about that. As to, is that something that really adds to the breadth of healthcare, lowers the cost of healthcare?
Right.
We'll have that conversation.
Right. Let me ask you about two more things, and we'll go to questions from the audience. Mental health policy has been a big topic of conversation in the building. It's healthcare of a sort. I mean, it is healthcare, right? It's just an isolated topic that gets its own attention offline from many of the things we've been talking about. For Price from Amarillo, your colleague, Republican colleague, Joe Moody from El Paso, your Democratic colleague, appointed by the Speaker, chair and vice chair of a select effort to look at mental health policy. We kind of have been playing catch-up on that, as we've been playing catch-up on a lot of things of late in the budget, Representative Howard. What can we expect on mental health policy? What should we in the next session?
Well, I'm very pleased that Speaker Strauss has put mental health as one of his agenda items for the next session, so I think we will have some focus on it. We did make some big strides last session. I don't remember what the exact number was, but a substantial amount of money.
Several $100 million have been
yes.
applied to this, right?
Right,
Yeah.
exactly. And spread across many agencies.
Right.
So it's been a priority for us to look at this and address this. As you mentioned a while ago, part of the problem is still a lack of providers, so we have more to do there. What we're going to be able to do this session, I'm still not sure. We know that there's still great need out there.
Right.
We have a lot. We still have waiting lists. We still have issues with our prison system. So how much of this is going to require funding?
Yeah.
That gets back to be the problem with a tight budget as to how far are we going to be able to go to keep making progress.
And Representative Zerwas, this is what I think most people fail to see immediately on mental health, is that it is not only an issue of health care, but it's an issue of criminal justice, education, immigration. All these topics have a mental health policy component to them. So when you spend money on that, it's a horizontal spend, not a vertical spend.
Exactly, and I think if you look at how much the select committee dug into this, it's literally billions of dollars that is being spent on it. We talk about we're going to put a couple $100 million more into it, and yes, it's spread out over different things, but it's spread into a pot of money that is in the billions of dollars.
Yeah.
And so, I don't think we can be criticized too much, from the standpoint of a lot of money going into this, and especially over the last couple of sessions since 2011, we've really pushed a lot more money into this particular area. My sense on it is we probably need to look at this in a much more transformational sense.
Yep.
What are we doing that's not really getting our arms around it such that the criminal justice system continues to be inundated with people that require mental health treatments?
County jails have become the de facto psych wards of the state, right?
Exactly, in many cases, and so, our state hospital system, it's largely, it's psychiatric care and stuff like that. It's in a very difficult place right now. And so there's a lot yet to be done. If we start thinking of mental health the way that we sort of started thinking about CPRIT and cancer care, maybe there's a big play here that we need to be talking about.
Right.
Well, in a sense, that may be what we need to be looking at. And so, if we think about all the money that we do have plowed into it, do we really need to be thinking about something that's much more transformational in terms of addressing which is a big deal? I mean, one in four people have some kind of mental health condition out there and stuff. And so it's something that, in terms of its frequency and so forth, obviously it's one of those big things.
The last thing I want to ask about is kind of a wild card issue that has come up back on our radar screens yesterday. The CDC put out a warning in Brownsville for the Zika virus. And I said the Zika virus kind of came into our consciousness and then kind of left our consciousness, came back to our consciousness, went back out. Do we have an infectious disease problem in Texas that we need to be concerned about? Are you all going to go into the next session thinking about these more global healthcare problems that have visited themselves, Representative Howard, on Texas? Do we need to do anything about this? Should we be freaked out about this?
Well, we always need to be doing something about this. We're going to have all kinds of issues continually with the global world that we reside in, and we've had a variety of experiences over recent years with some kind of infectious disease issue that
Ebola
we need to
in
address.
Dallas.
Yes.
We've had a couple of these come up.
Right. So do we need to be freaked out? I don't know about being freaked out, but at the same time, do we need to take this seriously and figure out how we need to address it? Absolutely. Yeah. It's one of many things. I mean, there are so many things that we need to be looking at. The increase in maternal deaths that's occurred that we need to be addressing. I mean, there's a long list. Zika's one of them.
But it's only one.
It's only one of many.
And I would say, and Donna and I are side by side on this one, is immunizations. There's no greater accomplishment in public health than immunizations.
Huge.
And yet we are seeing an increasing number of people, due to conscientious objection or whatever, to step out of getting immunizations. And we're seeing measles, we're seeing mumps, we're seeing things that we haven't seen before. And
you believe that the conversation around vaccines is a non-starter? People should just be vaccinated, that's it?
Oh, as a physician, yes. I absolutely believe that. And as somebody looking at it from a public health point of view. And I have a lot of people come to my office who are opposed to vaccines, and I very respectfully listen to them and try to understand where they're coming from. And that I'm totally unmoved on it, yes. And if you look at a place that just makes Zika pale, that's influenza vaccination.
That's right.
You know, that is a place that, you know, we required that of hospital personnel. We passed a law, I think, back in 2011 on that, in fact. But, you know, right now, you know, if people aren't immunized for influenza, we're going to see a significant number of deaths, not just falling sick and home for a few days, but deaths related to influenza. And we see that every year. And that is a place with increased uptake of influenza vaccine. We could see lives saved by huge numbers.
Now, you know, just again, last point on this, you know that the pushback from some in your party and some particularly in the grassroots movement is that there is something inconsistent with, on the one hand, being an advocate for immunization because we need to do it for the benefit of the entire state, and on the other hand, liberty. That if you're committed to liberty, as so many people in this state are, that you should be permitted to do whatever the hell you want as it relates to this issue. And you say what? Pretend I'm Representative Stickland. I'm just going to use him as an example. Your response to that is what?
Yeah, my response to that is the same as secondhand smoke and so forth. I said, fine, I respect that, but don't, you know, have a negative impact on me and my family and the people that are important to me, you know, by virtue of not doing something that clearly is interest in the public's health. And so I could probably, you know, rattle off a whole bunch of others like that, you know, but when we get into some of these situations, you know, I said, look, I try to understand, I try to be respectful. If you're a conscientious objector, I want to understand why. If you have, and there are some, you know, physical illnesses and things like that say you probably don't want to be getting, you know, that vaccine in particular and stuff. But in general, you know, I would say, you know, that vaccine uptake is probably one of the biggest, most important things that we could try to move forward on in the next legislative session. I don't have any idea what that legislation would look like. It will create a significant amount of concern by some parties out there, depending on which way you go with it. But there's a place, I think, Donna, it's Mississippi, that has one of the highest vaccine rates.
That's right.
And it's because you can't go to school unless you're vaccinated.
They don't have the exemptions.
That is not the law in Texas right now.
Well, and to your point, though, about the people who have need for medical exemptions, they're the very people we need to be protecting with as many people as possible getting the vaccinations, because there are vulnerable members of our public who cannot get vaccinations, and they need to have the herd effect in place to protect them. You know, the liberty thing, we all get that, but when it crosses the line, when your liberty imposes some kind of a detriment to the larger society, and that's what happens in this case. The kinds of legislation that I have and that I know others are looking at have to do with the registry, which is not about the exemption, it's about the registry, which would change it from, currently we have an opt-in system, which is bureaucratically unwieldy and unnecessary when 95% of the population wants to have the data in there. So we want to do that. Continue to have problems, pushback though, from the people that it doesn't have anything to do with getting the vaccination, it's just getting the information so we can make good public health decisions about it. And also a piece of legislation to educate people when they come in to see the physician or their primary care provider, requiring that they have been provided similarly, I guess, to what's been required with some other things like, say, abortion, where you're required to have information shared with you by your provider before you are allowed to get your exemption. Not to prevent you from getting it, but making sure you're informed. It's informed exemption, yes.
All right, let's stop there. We have microphones.
Is my microphone on? I'm Dr. Ruth Berggren.
Yes.
I direct the Center for Medical Humanities and Ethics here at the UT Health Science Center, and I also teach global health. And this week, the students asked me to come and speak to their class on women's health about women's global health. So I had to do a little homework, and I went in there to tell the good news about how the world, through the Millennium Development Goals, has achieved almost a 50% reduction in maternal mortality over the last decade and a half. But I was shocked, and I hope my colleagues here will share my dismay, to learn that in the same time period, actually in a shorter time period, from 2010 to 2014, while the rest of the world was reducing maternal mortality by half, in Texas, maternal deaths rose by 79%.
Indeed.
And I'd like to ask you, and ask your help, to explain this to us and tell us what you think ought to be done about it. Thank you.
Representative Howard, I know this is a big issue for you. You've talked about it quite a bit. You mentioned it today. What's the cause of this?
Well, that's part of the challenge here, is finding out what all is going on here. We do know some information already. in terms of this having to do with drug addiction is part of it. Cardiovascular disease is part of it. There's also a suggestion that discontinuity of care may be part of it. We have a system where women who come through the Texas Women's Health programs, that they are in one program when they're not pregnant and another program when they are pregnant, and then get into another program after that, and that this may impact their receiving the care that they need. They get Medicaid coverage. Women get Medicaid coverage only when they're pregnant, and then it goes away 1 or 2 months, 60 days after they deliver. If they are not immediately enrolled in something else, then they may fall through the cracks and not get care, and some of these deaths have occurred after that point in time. So there's there's many factors here that need to be looked at, they need to be addressed. This is a huge and serious problem.
Chairman Zerwas, why is an increase in maternal deaths of 79% over that short period of time not an emergency item for the state of Texas?
Well, I think it's one that certainly is going to rise to the top, especially I think within the Public Health Committee, and it will, as Representative Howard has said, it's going to require us digging deeper in to understand it. Obviously when you sort of think about maternal deaths, that's not an immediate period of time solely, that somebody has delivered a baby. I think it says, Representative Howard says, it's for a period of a year after that you look at what happens to the individual, and there are, obvious circumstances, variety of factors out there. But one of them is that, should we not be looking at making sure that women have, at least a year's worth of service out there? And we have talked about this before, that, maybe the right thing is for, let's not interrupt their services if they're on the Medicaid program at 60 days, do they have that, that maternal depression, postpartum depression that can occur, which has sometimes some catastrophic things, obviously not the sole driver here, but I think it's many things. But one of them is that at least we can look at from the perspective of making sure that health care is accessible is this 60-day versus a longer period of time.
Longer period of time.
Whatever that might be,
Maybe we could look at actually providing continuous coverage throughout childbearing years instead of just 1 year. I mean, I think that it would make a big difference if we had women receiving the kind of coverage that they need, the kind of care that they need to get the healthy women checks and services, but also make sure they're getting prenatal care from the get-go, as well as the postpartum care, as well as the contraceptive and family planning care. That would go a long way, I think, to addressing some of the concerns we have in our state.
And I think that comment is a reflection of this is a pretty complicated thing that goes into it, but perhaps at least one of the things that we can do is to make sure access to care is not interrupted, if that's in fact one of the things contributing to the problem.
Sir.
Thank you very much. Gijs van Oort with HASA. I'm just listening to the whole conversation, which is excellent, by the way, but it looks like we have a population that's going to be in need for certain. That's not going to go away here in Texas. We have an issue of funding that is questionable at this particular point. So is there a way in between to look at efficiencies in the system? Dr. Zerwas brought out telemedicine as one potentially alternative. We're very involved with health information exchange, the secure exchange of patient data. It seems that could address several of the issues. Is it a possibility for the legislators to start really putting some more teeth in some of those types of initiatives who are going on in the state but are still very much kind of in an enterprise situation? But if there is some kind of support that the legislature could give, look, here's some information exchange as an example, telemedicine, give us some guidelines, tell us what can be done. That might be a way at least.
Maybe the thing to do is to weigh in on the side of innovation that might ultimately save current dollars that we're spending, rather than having to find new dollars.
Correct, yeah. My sense is, and it's actually a step beyond what you mentioned there, and that's having that information available, is how do we transform the way that we all get paid, for what we do. And right now we get paid for doing things. I get paid for doing an anesthetic, What we probably need to look at is how do we get paid in terms of our performance. And there's a lot of this going on right now, and for a lot of us, it makes us a little bit nervous. But the bottom line is that if we look at performance-based and look at quality and efficiency in terms of ultimately how we get paid, I think what we'll see is the ability to drive down a lot of those costs out there. And part of that is having health information and health information exchanges in order to be effectively understand what we're doing and what works and what doesn't work.
And that's part of what the 1115 transformational waivers are supposed to be doing, too.
Right.
Right.
Yeah. I can take one more, I'm sorry to say. Sir?
My name is Ryan Renshurst. I'm a general pediatrician. Question about Medicaid. So children make up nearly 75% of our Medicaid population here in Texas, yet they account for only a fraction of the costs. Organizations such as the American Academy of Pediatrics are opposed to block grants for fear that kids might be cut. So if and when that does happen, how do we in a state that already has a poor track record of taking care of our most vulnerable make sure that kids don't get cut more?
Dr. Zerwas?
Well, great point, and then good to see you again. What we need to do is to be sure, one, we're all aware of that. And I don't think there's anybody that wants to go out there and say, hey, we got a block grant, and the way we can make this work is let's cut out 25% of these children, you know, and let them just fly on their own, and hopefully they'll get care somewhere. That's obviously not what we want to do. And so I think that, again, when we go back to looking at how do we best utilize those monies that are now, you know, down with us so that we can continue to deliver high quality but cost-effective care is the bottom line. And we don't want to restrict access. And if we look at Rhode Island as an example of a state that took on a block grant and actually made it work, you know, they did save substantial amounts of money without compromising access and maintaining quality. You know, it's going to be, not only is the way we're getting paid transformational, but from the federal government point of view, but how we deliver care and ultimately get recognized through payment for that care is also going to be a transformational thing.
I will say I think you have reason to be concerned, and we need to be paying attention. If you look at what happened with the reimbursement rates for the disabled children, that was the red flags were raised there partially because of what was perceived to be higher reimbursement rates than were done in, I think, 11 other states, and then also because of the uptick in the number of children being seen over a period of time. You know, there was never a good explanation about that as why that was such an issue, because the fact is these were eligible children. And when sometimes we have a problem, I think, with actually having eligible people take advantage of what they're eligible for. That increases our caseloads, and oh my gosh, that means we have to spend more. That's what it's there for. And so I would be concerned, by virtue of that example, that we still are trying to balance the budget on the backs of children, as you mentioned a while ago, with special ed, the disabled kids, the things that we're seeing over and over again, the foster care kids, so we need to pay attention.
Thank you so much for being here.
Thank you.
Great to have Dr. Zerwas and Representative Howard with us. Please give them a big hand. Great conversation.
Thank you.
Thanks to all of you for coming today, or if you've come to our events in the past. Dr. Hemmers, thank you so much for having us. Merry Christmas, happy holidays. We'll look forward to seeing you next year. Thank you. Thank you.